Good afternoon, I'm Dr. Tartaglia,
I'm Dr. Bone. Welcome to Yodo.
and we're here today to talk about the routine home level of care for hospice patients.
A patient on hospice has a life expectancy that's limited to 6 months or less because of a serious illness. And most patients want to be cared for in their own home. They prefer to be at home. And that's what the routine home care level is all about. It's about having an extra team that will come to your house with multiple members of that team to help provide that care. Your family's going to provide the vast majority of the care. Maybe you don't need much help at this point in time, but they have access to the nurse practitioner, physician, aide, chaplain, social worker, volunteers, dietitian, pharmacist, music therapist. I mean, the list just goes on and on for all of the people that you have access to come to your home, and you don't pay for it.
Yeah, and the majority of patients that decide on hospice services do get admitted on the routine home level of care. About 75% are the routine home level of care. And the reason why patients decide to invoke the hospice Medicare benefit is because they do have a disease prognosis of 6 months or less, and they are tired of going into the hospital.
Tired of going back to multiple physicians that just tell them everything looks great for the condition you're in good condition, and they know I can't do what I used to do. I can't walk the way I want to walk. I'm not strong like I used to be. I'm having trouble because I'm taking so many medications. I want my pill burden decreased, but I still want to feel good, and I'm tired of going back to all these different doctors that can't cure what's broken.
Right. And sometimes patients don't think that they need hospice, right? Because they are independent of their activities of daily living.
Functional.
And they're functional. But what I always tell patients is, give us a try. Try it out and have people come out. Because what I have found in my experience is by having a nurse or team members visiting the home, we're able to anticipate when things go wrong and really prevent disease progression.
You have a nurse that's going to come by no less than once a week. And that is so very important because she's going to see you in your own environment. She's going to review all of your meds. She's going to help your family set up the pill planner or entirely do it for you. And she's going to count out those meds to make sure that you have plenty of everything on hand. Your routine meds, your as-needed meds, and if you want your vitamins or your supplements put in there, she can help you with those as well. And then if something is going to run short, she can make sure that your physician is contacted and that's refilled in a timely manner. And it's not going to all fall to your family to have to do all of those things.
Right, and hospice does pay for the medications that are related to the terminal illness, and even if medications are prescribed that are not covered by the hospice Medicare benefit, that nurse can still call them into the local pharmacy and have it be filled under your Medicare plan or whatever your insurance plan is for prescriptions.
So the disease, like if I had heart disease and I'm on service for heart disease, Medicare is going to pay for my blood pressure medications. It's going to pay for my heart medication. If I need something to help get rid of extra water, it's going to cover those costs. But it's also going to cover for some medications that are not really related to heart disease. It'll cover for anxiety, depression, for bowels, pain, shortness of breath. So broad global categories with multiple medicines within each category that hospice is going to cover for you. You'll have to go pick them up. I don't think they'll bring them with the nurse, but many pharmacies now have delivery services.
Absolutely. And what is nice about the hospice patients that are on hospice is that you do get those pill boxes filled. I can't tell you how many patients that I visit in my business that are not on hospice services yet, and what a burden it is to get the medications. Even if they're in pill packs when they come, it is very confusing for a senior citizen to manage 10 plus medications on their own.
I just had a patient that we saw as an outpatient that is on 32 medications. And some of those medications and supplements, some of those medications are dosed 3 times a day.
Wow.
That is a huge burden to try to manipulate and manage and navigate all those different medications being administered at the right time and make sure that they have the right refills. Many times when you've got more than one med, the refill dates don't always coincide.
Right. The other thing that a hospice provides when you're in routine level of care is a certified nursing assistant, which will come and help you with straightening up your room. They'll make your bed if you want your bed made. They will do light housekeeping, maybe do something in your refrigerator if you need done. And the big thing that they help is they will help you with your bath. And sometimes people don't want to get a bath or a shower with the CNA, but they don't have to be in there bathing you if you're independent, but they're there to assist to prevent falls.
So the aide will help with bathing and shaving and changing the sheets, and certainly a family member can do that. Some patients are more comfortable with a family member doing that. Other patients are like, I don't want my family in here when I take a bath. I'd rather have this other person come in than my family member help me with the bath. Hospices are very sensitive to that intimate relationship that is built between the aide and the patient. And so they are very reluctant to change that aide unless you have a problem with the aide that's coming to your home. And all it takes from you, if you're unhappy with a service member, you just call that hospice agency and tell them, my aide was rude, or she's rough, or I don't like the nurse, I can't understand the language that they're speaking because I speak Spanish or I speak English and their dialect isn't the same. I speak toddler and hillbilly, but I don't speak Spanish. She speaks Italian and English. So we each have our own language that we speak, and we prefer to have that information come to us from those providers in that language that's comfortable to us. So if you've got an issue with a provider, you let that hospice agency know and they'll change it out. But
Right.
once you've built a relationship with your aide, that agency's going to want to keep that aide in the home, especially if you like the aide.
I recently had a really funny lady. She's 97, okay? And she just recently went on hospice. And she is just a delight that I visit her in her assisted living facility. And she said to me, oh, if I knew it was going to take going on hospice to have this muscle man bathe me, I would have done it sooner. So she's a big Baywatch fan, and her aide is male. So you would think, right, 97-year-old Midwestern lady, very prim, very proper, but she likes her aide, and she's having so much, she's now compliant with bathing, and her family is so relieved by that. Because a lot of times seniors don't want to bathe because they're afraid of falling.
The bathroom may be cold, the floor may be slippery, they may not be comfortable with the family being the ones to provide that bath. And so you think, oh, they don't want a stranger to do it. They might actually prefer a trained individual. Maybe they're a stranger the first few times they come, but then you're going to know that individual. But you'll have your aide that's going to come. Typically, the aide's going to come between 1 and 3 times a week. If there's a need, they will come every day. The nurse is going to come to your home, and she's going to come 1 to 2 times a week, minimum of once a week. We do have patients on hospice. The family does not want strangers in their home, but to receive that service, have that pill med counter set up, have those medications refilled, they need to be there at least an hour a week to evaluate the patient, do a skin integrity check, count the pills, do vital checks. There's a lot of things that nurse needs to do and will do to help the loved one, help the patient have the care that they need so that they can have every day be the best day they can.
Just so you all know, if you have a loved one on hospice, that doesn't make you have to stay home. The hospices will work around your schedule, and patients can go to stay with their loved ones. What we generally like it to be is a stay less than 2 weeks, because then you're able, if you're in the geographic area, it doesn't matter. If you're in the service area, you could go as long as you want, and they'll just change your address temporarily, and your team will follow you where you go. However, if you're out of your geographical area or the county in which the hospice provides service, then we like the visit to be less than 2 weeks. That just is less paperwork, but that's, it obviously can be whatever. If it's going to be a prolonged stay of more than 2 weeks, we normally help assist a transfer to another hospice provider, even out of state, just so you will have the same benefit there.
And if you just want to go for a day, you want to go for a day outing or a weekend outing, you just let your hospice agency know, hey, we're going to go to the beach this weekend, or we're going to go to the mountains this weekend. Or if you're just going to be out to dinner and you're leaving at noon and you're gonna take a drive, you let them know, hey, we're not going to be home that day. So you're not required to be homebound like you are with home health.
Exactly. And you call the shots and you have your own autonomy. So, for example, social workers and chaplains, as a hospice provider, we like to say once a month visits.
Mm-hmm.
That's the minimum that they should
Mm-hmm.
be going out as guided by Medicare. But again, if you don't want a chaplain and you don't want the social worker, you are in charge. So we honor the patient's wishes.
If you need them more often or less often, but the multiple team members will come to your home or to where you want to meet them. If it's not at the home, they'll come to you and provide that service and provide that care. And again, it's billed through your insurance, so you don't pay for it.
What I have found in my years of doing hospice is having those multiple touch points are so important for the patient. It really builds up their strength, their autonomy. I find that patients thrive and live longer on hospice services than those going in and out of the hospital. I always said I wish that somebody would pay for my study, but our studies for hospice and end of life are less likely to be published than some other things. But I do believe, and I've seen it with my own eyes for a fact, that it really helps the patients.
And it has been proven that patients who accept hospice earlier in the disease course, when they first hear the news that their life expectancy is limited, actually outlive that. Their medications are tightened up. They have a nurse that's going to come to their home that's going to find things sooner than if the patient might be left to their own, because that nurse is going to interact with the healthcare system for them. And I don't know if you've seen some of the other videos that we have on the channel, but even we have trouble navigating the healthcare system. It's a challenge now. And if you've got that hospice agency to be your advocate, they're going to do that for you. She's got a doctor that she can call directly and tell them, I need this medication refilled. This medication may need to be reduced because their blood pressure or their blood sugar is, changing. And now they have a new rash and they've got burning with urination. So the nurse is going to tell the doctor, I would like an order for a urine test. I would like an order for a cream for this rash, and I need a refill sent. And, the doctor's going to be able to hear that report and listen to that information because the nurse is there. And if the physician needs to, they can do a video visit right while the nurse is present.
And I find when we were working as a physician, working within an interdisciplinary team, it is so important. Every member brings something to the table. So for me, the CNAs are looking at the skin, the certified nursing assistant. So they will be able to tell us when there is skin breakdown. And for a diabetic patient, that's really important that we're on it very quickly and treat it, because these patients are weak, they're immunocompromised. And without proper treatment, their rashes can advance to a systemic infection.
So these are people who come to you and provide this service. The nurse is licensed and she went to school for that. Dr. T has just talked about the certified nurse assistant, the aide. They have gone to school and taken training so that they know how to do these things. The chaplain has obviously gone to way more school than what I realized that they went to become a hospice chaplain. And then the social worker, many of them are licensed certified counselors, LCSW. So they can counsel the entire family. And you have access to this highly trained team as well as the physician and the nurse practitioner. Plus multiple people behind the scenes that are not going to darken your door, that you don't have to see. You can have access to a speech therapist if you need to, if you need a therapist to come by to help with training or help the family learn how to get the patient from the bed to the toilet or the bed to the commode. You have access to all these people who are licensed and trained individuals that your insurance is going to pay for, that Medicare is going to cover, not going to cost you anything. And it's a tremendous service that comes to your home. And that's what the routine in-home care is, and that's what it's for.
Yeah, and I also want to add, for example, if you are to fall or say you have shortness of breath and you need an x-ray, that is done in your home. I mean, in addition to physical therapy, occupational therapy, speech therapists that comes in to help with dietary changes, hospices are contracted with a radiological team that will come out and do all of that in your home.
So if you trip on on your, rug or something, and your ankle is twisted or you hurt your wrist, they'll send a mobile unit out.
Yeah. And the reason why we're doing this video for the levels of care is, well, first of all, the main reason is our viewers have asked us for it. But for us, it's really important because we want to demystify, debunk the fact that you go on hospice and you die instantly.
If you wait till the very last minute, there is nothing left to do but go on hospice, and then you will die. But you didn't get the benefit of that. And I used to, when I would talk with the marketers about teaching physicians, because they go to their office and talk to them about patients that have serious disease, what I'd do is I would make some cinnamon rolls, or I would bake a pie, and I would take it and I would cut it up and I would give them each a piece of pie, and I'd let them take a bite. Now that's really good. You like that? Now throw it away. You don't get the rest. You only got a sample of it because the patient waited so long to accept service, they didn't really get any good out of it. So you want to take it at the earliest opportunity. If you don't like it, get rid of it. Right. You may think, oh, I tried it for a week and I just don't need it right now, or I don't want it right now. But at least you tried the service. But to not even try it out of fear is not the best choice for you, because you can get a lot of good out of it, and it may make your life better, may make your quality of life better, and it may make you live longer.
Yeah, and it really will lessen your stress, right? Because what is the most stressful thing when we talk to patients is going into the emergency room setting. Dr. Bone, you've recently had that experience. Mm-hmm. It's stressful, and we're physicians. I mean, and I can't even imagine when I am in that type of situation. I think of our poor patients that don't have the knowledge base that we have, the wherewithal. It's really scary.
It's difficult to access the system, and then you don't know what's happening. When you have a hospice agency, you can call them and ask them, hey, are you coming today? You said you'd be here at 3. It's, 4 o'clock. And then the nurse can tell you, I got held up at somebody else's house and I'll be to your house shortly. Or maybe it's earlier in the day and they can tell, she went to somebody's house and that patient's going to need a lot of care. The nurse or somebody from that hospice may call and tell you, we either need to reschedule or we're going to send somebody else to your home today. And they'll give you that option as to how do you want to handle it, because the nurse has actually got tied up with somebody else. And you want them to be able to provide that care, because one day it may be you that needs that nurse to stay at your house a little bit longer. When you're in the hospital, you have no idea what's happening or when they're coming back to you. We go to Disney sometimes. You stand in the line, you can see the line is moving or isn't moving, but you kind of have an idea of where you're at. When you're in the hospital, you have no idea where you are in the line, how many people are ahead of you, whether are they going to come and get lab work, are we going to do imaging, am I going to get an x-ray or a CAT scan, when is the doctor going to come back? You don't know. And with hospice, when you're in your home, they're a phone call away, and you can call and ask them what's going on, and they're going to let you know.
Yeah, and they'll be there to educate you 24/7. So in the middle of the night, if you have a problem, you call them and they'll walk you through the problem. They'll send a nurse out to help you if you need it.
For me, the best part of routine in-home care is it means you're not having really any acute symptoms that need to be managed, and you're in your own home.
Yeah, and that's the best part. And what's the best part is after you've taken care of that patient and developed a rapport, and it comes to be their 6 months is up. They're afraid. They don't want to graduate. And it's really wonderful when you can still find reasons to keep them certified and keep them going. And most do. They are able to stay certified. Some do graduate and they're elated.
Sometimes we have a patient that has a terminal illness, and what we have done is we have stabilized them. But it's because of the support. It's because the aide is coming in. It's because the nurse is coming in. It's because they have a bedside commode. It's because we've provided a lift and oxygen that the patient has been incredibly stable. But if we don't provide that service, the patient would no longer be stable. And so Medicare doesn't make us leave because the 6 months is up. We can show that the patient is doing well because of the services that we're providing. And so then we're allowed to stay in, and we're allowed to recertify that patient for another benefit, period. And that's on the hospice. That's not on the patient. So sometimes patients do extraordinarily well and they really don't need us anymore. And sometimes it's the patient that says, I don't need an aide to come to the house. I'm getting my own bath now. And myself or my family, we're able to manage those pills. But sometimes it's the hospice agency that says you really don't need us anymore. And so we're going to pull out for a period of time. It's likely that they're going to need us again, because the reality of death is true and we are all going to pass away. But you may not need us now. You might need us again in 3 months. You might need us again in 2 weeks because maybe something happened. But you may not need us for another 6 months. And when you do need us, we'll come back.
Exactly. So it's just beautiful when we have graduations from hospice and you know that they're going to come back because they've received such great care, and they tell all their friends and their family because they're so elated that they're not in the hospital. And we always do get them back, and sometimes it's in a year, 6 months, 3 months, like Dr. Broad said, you just never know.
I got to take care of a patient, I wouldn't say recently, but within the last year, that was at the hospital. He came in, he had a viral infection in his lungs, and he was given medication, and the medication caused him to be more sleepy. He wound up on a ventilator. Then he declined over a couple of weeks. And all the time, we're doing these imaging of his chest, and he's got this pneumonia. When the pneumonia cleared up, we found a mass. And so sometimes pneumonia can actually hide a mass on imaging. And the oncologist saw him and said, he is so weak and he has been so severely ill, we don't want to treat him. And so he came to us to have symptoms managed at our inpatient unit. And while he was there, he got better. He got stronger. And he ended up going home and received hospice care while he was at home. And he was so determined that I'm going to get better. And he was at his own home, so he was feeling better. His daughter took FMLA care or FMLA time. His son took some FMLA time, and they were able to provide the care that he needed at home. He had the hospice nurse coming at first 3 times a week. He had an aide coming 3 times a week. He had a couple of wounds on his lower legs, and those healed up. And over a period of about 3 months, he got so much better that he graduated from hospice. And we got such a wonderful card from the family telling us, we thought when he was at the hospital, everybody kept telling us he was going to pass away, that he was going to die. And you told us, because one of the things I told him when I first met him is, hear what every service has to offer you before you make your choice. It's like going to a car dealership and you pick the first car you see. That may not be what you want.
Yeah, each hospice has their own flair, their own vibe, their own staff, and their own emphasis. Like, everyone is individual and each patient is individual. I have a similar story that about a year ago I met a patient. I meet my patients now through my business that are going through transitional care. Family is out of state and they're all out of their minds, meaning they're trying to figure out what's going on. So I help them with prognostication. And this gentleman was very ill and has a terminal illness that's related to his heart. But with the hospice care, they've healed his wounds. They've helped his exacerbations, his shortness of breath that he has. And yesterday he checked into his hotel in Disney for a week. I mean, he's going to go to Disney and just go on the scooter. He's not going to really go to the parks. He wants to be able to eat at the boathouse in Disney Springs.
Okay.
And he wants to be able to sit by the pool and read a book. And I mean, this is something that I never dreamed could be possible for him. So it's just wonderful to know that there is hope for people that are on hospice, and with the routine level of care, that team not only coordinates with their medical director, but that nurse is so phenomenal. She'll send me reports of when she sees him and what's going on with his wounds, so I oversee all his care in addition to the team.
We love being able to help provide care, particularly in a patient's home, and have these kind of success stories. If you're offered hospice, think about it seriously, accepting hospice. You don't have to say that you don't want to go back to the hospital. You don't have to say, I don't want to be resuscitated. You can still choose those things if that's what's right for you. But accepting that hospice earlier and working with that hospice agency to provide you the kind of life that's meaningful for you may actually provide you a better life, a better quality of life, and a longer life.
Please let us know if we missed anything in this conversation about routine home level of care for hospice. We're curious to know what your thoughts are, what has been your experiences. We're geographically located in Florida, and there's a lot of differences amongst every state. So just let us know, and for any Canadians that are our viewers that watching, I know that the hospice looks differently there too.
If you've got something you want to let us know, please drop it in a comment below, and we'll see you the next time we bring more information to you.
Thank you so much for joining us. Bye now.
Bye.